I start to introduce the subject of my presentation, I would like to draw your attention on the relation between equity, between inequality, between innovation and regulation of financial aspects in healthcare systems like they exist in Europe. The question I will raise is if equity, which is definitely belongs to our common values, that if equity can hamper some dynamic aspects of the development of healthcare systems. So we are in good hope that we can return to the electronic mode now. I would like to start with a figure, thank you, with a figure that you're very well acquainted with. The development of life expectancy here in Germany, and the question, what causes this nearly linear development of life expectancy? Is it a miracle? Does it come from God? Will it last forever, the increase? Is it something coming from nutrition, from something else? Or is there an impact of healthcare supply, medicine, and access to medicines? Please allow me a short digression to the experiment, the natural experiment that took place in Germany, just to come back to the discussion of yesterday, what causes increase of life expectancy. This is the curve for Germany as a whole, integrating East and West Germany, and these are the curves for West and East Germany, broken down for men and women. And the interesting, I would say, the shocking thing is that we have extremely divergence of the development of life expectancy if we observe male or female parts of the population. We observe that in East Germany there is a constant decline from 1960 to 1990, the year when the year of the unification of Germany, the year of the 1989 was the year of the great change of in the whole Eastern Bloc. You know that very well. Not far from here is Checkpoint Charlie, where everything started in Germany, 500 meters from here. And in the same period of time, the first half, from 1960 to 75, we had a parallel development in the West, and then we had a sharp increase of the speed of increase of life expectancy in the West for men and women as well. And this continued more or less after unification. And after unification, we observed a strong increase of life expectancy in the East. The difference between East and West was around 4 years, which is enormously high. And I think every theory on the development of life expectancy should be tested against this reality. And we have to discuss mainly what happened after unification. Everything developed the opposite way as expected. Unemployment rose very much. The society that has been established now in East Germany was much less based on equity, although life expectancy rose very much. And the question, among others, is if the healthcare supply of healthcare services had at least a part, a role in the increase of life expectancy for the East German population. So this is my digression, and I come now back on the question of healthcare, the relation between healthcare and health. There is a long tradition in public health, starting with Thomas McEwen, who showed us the relation between mortality from tuberculosis, which declined, totally unrelated to progress in medicine. It declined from 1840 to 1960, more than linear. Only in the 40s a therapy has been developed, a medical therapy, when the mortality rate nearly went down to 10%. So McEwen stated that healthcare and health have more or less nothing to do with each other. This perception persisted, and there was a big debate in the United Kingdom, the BMJ, and this quotation shows that even in 1994, the majority, I would say, the majority of experts believe that there is no relation between healthcare and health, and therefore money invested in the healthcare system is more or less wasted money. This perception changes more and more, and an OECD study from 2000 was, as much as I know, the first that showed that stated a significantly positive relation between healthcare expenditures and health. And what is health care? It is not a static factor. Health care is something which develops, and if we take a look into a textbook of evidence-based medicine, the first thing we learn is that we should burn our textbooks, because knowledge is renewing every few years. So knowledge about health interventions and health interventions are a very dynamic thing, and therefore that's the base of my presentation. We should focus on innovation if we talk about health for all. A strong evidence for changes in healthcare provision, easy to describe part of healthcare provision is the prescription of drugs. Here for the country of Germany, 2008, among the top 24, we see about the half of the drugs are of proven efficacy and life-saving, and the other half is of proven efficacy and not life-saving. These are the main drugs in Germany today, and due to the IGES research, which went back to the 70s. We have data on the top 24 in 1975, and the picture was completely different. We only had one drug with proven efficacy and life-saving, and a few others of proven efficacy but not life-saving, or not necessarily life-saving. And a lot of other drugs, the majority of other drugs, are, from a today's standpoint, they are still not of proven efficacy. Some of them are even not available today because they are so undiscussable in the medical community. There are real weird drugs among the first 25. This is a tea containing birch leaves and some other weeds. These were among the top 25. And besides them, we had among the top 25 were 3 benzodiazepines, which is undiscussable today, and maybe caused the sleepiness of Germans in the 70s. So there's a lot of progress in research which is transformed to medical care. If we look at the market shares of those drugs in 1975, these bars, and compare them with the market shares today, we see that they are more or less wiped out. They are not anymore in use because they are not consistent with efficacy proofs. They are not consistent with evidence-based medicine. If we take this change, we have to look at a very important movement in modern medicine. I like to call it the war against heart disease, which started from the results of the Framingham study, which has been discussed and transformed to the healthcare system, accompanied by a series of invention of new drugs, of new principles of interventions, also by surgical procedures, and not to forget, also by preventive measures. Compared to the 60s and 70s, our nutrition changed very much, and smoking and alcohol use are seen in a much different light today. And it can be shown that in the mid-80s, this offensive against, this attack against heart disease came really into action, and I state that this caused a decline of cardiovascular diseases, cardiovascular causes of death, which was much stronger than all other causes of death. From 85 to 2006, cardiovascular causes of death declined by 49%, whereas other causes of death declined by 23%. In the period before, we had a decline of cardiovascular deaths by 19%, but by 31% by other causes of death. That means joint action and investment into coronary heart disease, more or less coronary heart disease, was a very successful strategy and can be observed, can be resulted in a reduction of cardiovascular diseases within 20 years by the half, which is enormously strong. By the way, I think we are approaching now the war against cancer, and I am quite optimistic that we observe something similar with cancer as cause of death in the next 10 to 20 years. So this was the good part of the message. The bad or the problematic part of the message is that this causes additional costs to the healthcare system. Here is a analysis of the expenditures of the German statutory health insurance for biologicals. That means drugs generated by biotechnological processes. Altogether, there was an expenditure in 2008 around 4 billion euros, and it can be expected that in 2020 this will be around 10 million euros, caused by a strong activity in the pharmaceutical industry, in science, in medical science, life sciences altogether, towards the invention, development, and also the market launch of drugs against orphan drugs, orphan diseases, cancer, autoimmune diseases, and we also expect a particular increase of drugs that we even do not know today, which are in the pipelines of pharmaceutical companies. So a strong increase of healthcare costs due to a strong innovative process. What is the reaction of countries, of different countries, to contain these costs, to reduce the increase, the yearly increase? One of the strategies, not the only one, but one of the strategies is to prioritize healthcare expenditures to those drugs who are of proven efficacy, which is a rational strategy to sort out useless services from effective services. And the majority of a series of countries we compared in a study had instruments that combined price regulation with utility assessment or appraisal processes of new services or new drugs. There were, in this number of countries, there were 2 countries that had no such instruments, the United States and Germany, but countries as Sweden, Great Britain, France, they did have it, and I would say that there is a relation between the tendency of high equity countries, I call high equity countries who have a high estimation for health, equal health care access, and I think that high equity countries do have these instruments, has something to do with each other. This figure shows us the results of regulation processes. And the US, in this figure, after a study of Danson and Furukawa, the US as the gold standard for the penetration of new drugs is plotted here against a selection of countries that I count to the high equity countries: Canada, Great Britain, France. And the figure shows that all high equity countries have, in the early phase of the market launch, of the penetration of new drugs, have compared to the US, relatively little penetration, which rises with the years. At the end of the observation period, after 10 years and later, all high equity countries have a higher penetration than the US, more or less due to the fact that there's no equal access for drugs in the United States, and that there's a considerable part of the population who are not able to access these drugs. On the other side, in the early phase, the US are very liberal to let new drugs into the market and let at least a part of the population participate in these developments. What does late penetration mean? One aspect of late penetration is that the good thing is that it prevents patients from unsafe drugs, from drugs that turn out in the first years to be unsafe, to cause harm to the patients. The bad thing is that late penetration deprives patients of proven benefits. Here in this example, the curve of market penetration for statins in Germany shows that the level of utilization in 2006 is around 1,800 DDDs, 1,800 million DDDs, compared to 134 million DDDs in 1994, in the year when the efficacy of statins has been proven. And it took more than 10 years to tenfold the utilization of these drugs, which are with no doubt useful to prevent cardiovascular disease and death. And this development, this late penetration, deprives patients from an early utilization, from an early benefit of these drugs, and this is the negative aspect of late penetration caused by instruments of cost containment. So I come to the end. I would like to show the relation between equity strategies and innovation strategies, how they stick together. Equity and health for all are goals that we share, and health for all causes financial limits because the allocation of resources to the healthcare supply, healthcare services, is limited by definition. Financial limits are tried to be overcome by instruments of assessment, of appraisal, and this calls a late penetration for the majority of all of the patients, of the beneficiaries in a healthcare system. Late penetration for all is associated with little choice. If late penetration is allowed for all in the early phase, then this means that there is little choice for patients to go for drugs that are not on on the lists of the public systems. Late penetration, and this is now the relation to the production process of innovations. Late penetration is a weak stimulus for innovation, because if it lasts a long time after the invention, and it has to do with patents, after the provision of a patent, that after reimbursement, there is a reinvestment possible for those who provide the services. There is a weak stimulus. Early penetration could provide a stronger stimulus on innovation. Innovation, this is my hypothesis, has to do with health for all. If we have a strong innovation process, we can support the healthcare system with new services, new goods, and it can be shown in the past that new goods, new services help to increase the health status, and that the health status in countries like European countries is also determined by services that have been innovative in the past. The question is how the problem between financial limits and innovation can be overcome. Could be in the question of the limited choice, if we can allow a limited choice within healthcare systems that are constructed after I would say, the European model of public funding. And to stimulate your fantasy, I would like to draw your attention to a different market, and to the question how the airbag, which is an element in every car which comes to the market, how the airbag came to the market, to the car market as a publicly used instrument to reduce damage and the loss of lives in car accidents. This car, this is German now, some of you may read it. This car came on the market in 1981. It was the first in the world with an airbag available. Only one airbag for the driver, not for the seat beside the driver, and the price was 1800 Deutschmarks, which was 5% from the price of the car. At the same time, in 1981, this car came on the market where an airbag was not available. If it have been available for 1800 marks, it would have been 15% of the price of this car. So the willingness or ability to pay it, even if it had been available, would have been very limited to consumers of this car. 10 years later, in this car, the airbag was available first time. 10 years later. It costed 1100 Deutschmarks for driver and the seat beside, which was 6% for two airbags from 1800 marks, and you see that the relation is now the same. So the availability or the ability to afford an airbag has been reduced considerably. It's not 15% of the price of the car, but 6%, due to the fact that in these 10 years, the car manufacturers could earn money from selling airbags in expensive cars. And 10 years later, airbag is something we don't even think about, because it comes in any car that enters the market. So the message is that the early penetration of an innovation can help to reinvest investments in this innovative development, and help the penetration of goods that are of useful for everybody into the general population. And last question is, how could healthcare systems or policies stimulate the innovation process by not giving up their policies? There are three alternatives. First, they could allow early use of services only for out-of-pocket payers. This is something which happens nearly in every country in the world, but countries like Germany, they are not familiar with this, and it is not a popular policy to allow services for only those who can afford them. But it happens. The second thing is, healthcare systems could encourage the establishment of so-called innovation insurance schemes as add-ons. Innovation insurance schemes would be additional insurances for services that are not yet under general reimbursement schemes by the public healthcare schemes, but are in a waiting position, as we saw this in the examples I gave before. And the third, most likely the most strongest equity strategy would be the allowance of choice within public healthcare systems. In the example of Germany, that would mean that a part of the total budget of the healthcare system would be dedicated not to a general scheme, but to a scheme of choice, where beneficiaries can choose between goods or services that are not yet publicly funded, but can use a limited part of their insurance budget for individual choice, and to use services and goods along their personal preferences. And this would not only stimulate the innovation process, but would also put some pressure out of these appraisal and assessment processes, like in UK the NICE process, or in Germany the IGES process, which are very highly loaded with conflicts about the general reimbursement of goods, and if there would be an element of choice, there would be much less pressure in this process, and I would also say there would be much more scientific reasoning to take place against policy-driven decisions or budgetarian-driven decisions. So, thank you.